Welcome to this tutorial. We will go through the salvation protocol for evaluation of hypotension and hypoxia in the perioperative period. This tutorial is divided into 3 parts. Part 1 of the salvation protocol is presented here. Watch this on a laptop or desktop for a better experience. The salvation protocol is a focused ultrasound examination that is applicable to the perioperative period. It allows evaluation of hypotension and hypoxia in a focused and stepwise manner to determine the underlying pathology. At the end of this tutorial, you should know the basic principles how to make an assessment of hypotension and hypoxia using the salvation protocol. Further reading can be obtained from this recent publication in the Journal of Cardiothoracic and Vascular Anesthesia, Volume 35. The authors, Huma Fatima et al., describe the salvation protocol in detail here. The authors here propose a simple, sequential, and focused multi-organ approach, applicable for the evaluation of perioperative hypotension and hypoxia in emergency scenarios. The algorithm proposes 3 steps for the evaluation of hypotension and hypoxia. These are Step 1, evaluation of contractility and afterload. Step 2 involves evaluation of preload. Step 3 uses the lung windows to complete evaluation of hypoxia. The views described include the standard 5 POCUS cardiac views. The additional views include the left and right upper quadrants, aortic slide view and pelvis view. Finally, the lung windows are assessed. Let's have a look at the POCUS cardiac views first. Step 1 of the protocol involves evaluation of LV and RV contractility. Afterload is also evaluated. The 4 POCUS cardiac views are used to make an assessment of contractility and afterload. These are the parasternal long and short axis, apical 4-chamber and finally, the subcostal 4-chamber view. These are standard POCUS cardiac views, and we have covered them in separate video tutorials in the past. Nevertheless, we will go through them once again to give you a brief overview. A standard phased array cardiac probe with a small footprint is used to obtain these views. Let's go through the cardiac views first. The parasternal long axis view is obtained first. Place the probe in the 3rd or 4th left parasternal space with the transducer marker facing the patient's right shoulder or at the 10 o'clock position. Slight tilting of the probe may be required if the ribs are in the way. This view allows for assessment of the left ventricle, left atrium, ascending aorta, right ventricular outflow tract, aortic valve, and mitral valve. The descending thoracic aorta can be seen posterior to the left atrium and the posterior pericardial space is visualized. Quantitative assessments that can be made in this view include LV wall thickness, LV internal diameter, LA and aortic root dimensions and fractional shortening. Only the interventricular septal wall and the posterior LV wall is seen. The right atrium is not visualized here. The parasternal short axis is obtained next. This view is obtained by rotating the transducer by 90 degrees so that the transducer marker now faces the patient's left shoulder or 2 o'clock position. The transducer is kept in the 3rd or 4th left parasternal position. The LV is seen in its short axis. The papillary muscles can be seen when the LV mid-cavity is visualized. All 4 walls of the LV can be seen. These are the anterior, septal, lateral and inferior walls. This view is useful for assessment of LV global systolic function and regional wall motion abnormalities. Preload status and afterload assessment can also be made here. The right ventricle can also be seen in this view, and an assessment of RV size and contractility can be made. Tilting of the probe allows for the basal and apical regions of the LV to be seen. We next obtain the apical 4-chamber view. This view is obtained by sliding the probe towards the point of maximal impulse or the apex of the heart. This is usually in the 4th to 5th intercostal space in the mid-axillary line. The transducer should face the left axilla or 2 o'clock position. Structures seen in this view include the left atrium, left and right ventricles, mitral and tricuspid valve, interatrial and interventricular septum. The RV free wall is seen here. The RV is normally 2/3 the size of the LV. In this view, the lateral and septal walls of the LV can be seen. The apex of the heart is formed by the LV. The LV should appear elliptical in shape. We can assess the relative sizes of the LV and the RV in the apical 4-chamber view. Gross function of the tricuspid and mitral valves can be observed. Use color Doppler to look for regurgitation. The next view for assessment of contractility and afterload is the subcostal. To obtain the subcostal 4-chamber view, the probe is placed in the midline in the subxiphoid area. Here the probe is tilted cephalad with the transducer marker at the 3 o'clock position. This view is best obtained with the patient in the supine position with knees flexed. It may sometimes be uncomfortable for the patient, and the patient needs to relax their abdominal muscles. The structures seen include the left atrium and right atrium, the right and left ventricle and the interatrial and interventricular septum. This view is also useful for evaluating the pericardial space for effusions and tamponade. The interatrial septum and interventricular septum are perpendicular to the ultrasound beam and are seen face on. Atrial and ventricular septal defects are best seen in this view. The 4 views described thus far are used to assess contractility and afterload. The inferior vena cava is described here, although it is more relevant for assessment of preload. This view is obtained in the subxiphoid area with the probe placed longitudinally over the upper abdomen. The IVC is seen as a non-pulsatile structure or vessel that drains into the right atrium. IVC diameter can be measured 2 cm distal to the RA-IVC junction. The IVC diameter varies with respiration. The variability increases in conditions associated with hypovolemia. The IVC will be dilated and have reduced respiratory variability in conditions associated with obstruction to RV outflow, such as right heart failure, pulmonary hypertension, and pulmonary embolism. We will go through the 3-step process for evaluation of hypotension and hypoxia. Step 1 involves assessment of LV contractility and afterload. We then make an assessment of preload. This will be covered in part 2 of this tutorial. Finally, lung views are used to make an assessment of hypoxia. By using this stepwise approach, we are less likely to miss pathology and have a structured approach to assessment of the hypotensive and hypoxic patient. Let's look at contractility and afterload assessment. Eyeballing is an effective method of determining LV systolic function. By eyeballing, the LV systolic function can be divided into normal, mild dysfunction, moderate dysfunction, and severe dysfunction. This is an example of normal LV systolic function, with ejection fraction greater than 55%. All 4 POCUS cardiac views are seen here. Here we have an example of severe LV systolic dysfunction. The ejection fraction is less than 30%. The view shown here is the parasternal long axis. The LV on the left is normal. Compare this with the LV on the right, which is hardly contracting and has an EF of approximately 15%. In this apical 4-chamber view, the LV appears dilated. The LV walls are thin and there is minimal wall thickening and circumferential shortening during systole. The EF is 15%. When assessing LV systolic function, we should look at the LV in all 4 POCUS cardiac views. Let's look at LV wall thickness. Here we have the parasternal long axis view. The LV walls are significantly thickened. If we measured wall thickness, it would be greater than 1.5 centimeters. This is indicative of severe LV hypertrophy. Measurement of posterior and septal wall thickness is made in the parasternal long axis view, using 2D measurements or M mode. The red markers show the measurements for LV wall thickness. We can freeze the frame in end diastole for measurement of LV wall thickness. The white marker indicates the measurement of LV internal diameter in diastole. Measurement of the LV diameter in end systole allows for calculation of fractional shortening. Sometimes it's difficult to eyeball LV systolic function, and we can use quantitative methods of LV systolic function such as fractional shortening and endpoint septal separation. Let's look at EPSS measurement. We use M mode in the parasternal long axis to make this measurement. The M mode tracer is placed across the tips of the anterior mitral valve. We measure the distance between the E point of the anterior leaflet of the mitral valve and the septal wall. A measurement of less than 7 mm indicates normal LV systolic function. A measurement greater than 10 mm is indicative of poor LVEF. We can now look at the LV in the parasternal short axis view. By simple eyeballing, we can tell that the LV on the left is normal. The LV on the left contracts well and there is good wall thickening and circumferential shortening. This is in contrast to the LV on the right. Here the LV walls thicken less during systole and there is limited circumferential shortening seen. The EF on the right is approximately 15%. This view is also useful for looking at our WMA. The LV on the right has an inferior wall that does not thicken or contract during systole. This is an example of inferior wall akinesia. The parasternal short axis view is a useful view for evaluation of global and regional LV systolic function. Next we can look at RV contractility. The relevant views for RV contractility assessment are the parasternal short axis, apical 4-chamber and subcostal 4-chamber views. These are shown here. The RV is of normal size. The normal RV should be 2/3 the size of the LV. The apex of the normal heart is formed by the left ventricle. It is important to remember ventricular interdependence when assessing the RV. We need to look at septal wall movement as well when assessing the RV. Normally, the septal wall protrudes into the RV during diastole. In conditions of RV overload, there will be septal flattening as pressure in the RV increases above that of the LV in diastole. This will cause the LV to have a D-shaped cavity. In this apical 4-chamber view, the RV is severely dilated. It forms the apex of the heart and there is septal flattening. Let's look at the RV in the parasternal short axis view. The RV is severely dilated here. There is septal flattening in diastole, and the LV cavity appears D-shaped. This is indicative of RV pressure overload. The elevated pressure in the RV is higher than LV end diastolic pressure, thus causing the septum to shift inwards into the LV cavity in diastole. Such appearances may be seen in acute pulmonary embolism, acute fluid overload or any other cause of RV volume or pressure overload. We can quantitatively assess RV function with TAPSE. TAPSE measurement is made in the 4-chamber view with the M-mode cursor placed at the lateral annulus of the tricuspid valve. A normal TAPSE is between 15 to 25 millimeters. We will continue with afterload evaluation in part 2 of this series. To summarize, we have looked at the 5 POCUS cardiac views for evaluation of contractility of the RV and LV in this tutorial. Thank you for watching.